Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Kathrin Berg.
A colonoscopy. It is absolutely one of the greatest gifts that you can give to yourself to save your life. Colon cancer is one of the few cancers that's preventable, and a colonoscopy without question can prevent colon cancer. And how, you might ask? Well, suspicious polyps are removed during the procedure. Those polyps can turn into cancer, and thus those polyps are then removed. During the next hour, we have physicians answering questions about prevention, about diagnosis, and about the treatment of colon cancer. This evening is underwritten by the Texas Tech University Health Sciences Center, and we also want to thank the El Paso County Medical Society for bringing this program to you for over 28 years now. And you may notice that we are in a different location. This is the Turner Home. It is a home that is technically registered on the Texas Historic Landmark List. The Turner Home was designed by Henry Trost, and it was built in 1910. It's a beautiful place to be, and we're bringing it all back home with the El Paso County Medical Society. The society has been here since 1946, and we have been filming this show. We were just discussing this prior to the program. We've been in 5 different locations filming, so it's nice to bring it back home. We thank you so much for joining us. We're glad to bring you in on history and a lot of medical issues that we're going to be speaking about today. I'm Kathrin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Thanks again for joining us. I'm Kathrin Berg, and this is the El Paso Physician, and today we're going to be speaking about colon cancer, prevention, diagnosis, and management. We have 2 veterans with us today, and one person who is new, and I promised him we can ask him questions last. But Dr. Alejandro Robles, I would like for you to talk to the audience and tell the audience what a gastroenterologist does. And let me back up a little bit. We have Alejandro Robles, who's a gastroenterologist. We also have Dr. Mark Zuckerman, who's a gastroenterologist, and then Dr. Amar Callas, who is a gastroenterology fellow. And we're going to talk about the separations and differences of that in just a moment. But Dr. Robles, what do you do all day, every day?
All day, every day. Well, first off, thank you for having us here again today. So, as a gastroenterologist, we pretty much take care of the entire gastrointestinal system, from the esophagus to the stomach to the small bowel, the large bowel, the pancreas, the liver. Anything that can go wrong, we're here for that. Mm-hmm. We do procedures, endoscopy, to try and correct and fix any of these possible complications that could arise. And at the same time, we're also involved in preventive services like colon cancer screening, where we focus on preventing colon cancer, which we'll speak a little bit more later, but it is the second most common cause of cancer-related death in men and women. So we try and decrease the risk of this. Yeah.
And I don't think a lot of people know that, because you hear a lot about other cancers, but this is really one, and this is the preventable one, which
Absolutely.
is so great that we're here today about that.
Yeah.
Dr. Mark Zuckerman, again, everybody kind of does the same thing, I get it, but your everyday, day-to-day routine, what you do, etc., if you can explain to the audience what you do.
All right, so I'm a chief of gastroenterology at Texas Tech. So clinically, what we do is we see patients with disorders of the gastrointestinal tract or liver disease. But we see patients in the hospital, which is emergencies or inpatients, which is where I'm coming from now, and we see outpatients. And these are your usual outpatient problems that Dr. Robles just alluded to. In addition, at Texas Tech, we're involved in the teaching program, medical students, residents, and we have a big GI fellowship program training future doctors, future gastroenterologists. That's a 3-year program.
That's a 3-year program. What a perfect transition. Look at that. He already introduced you.
Yeah.
Dr. Kalas with an accent on the end.
Yes.
Very nice to meet you in person.
Nice to meet you too.
And
Thank you for having us.
talk about the fellowship. I mean, that's a nice way of setting it up. And what does that mean? So I think that people that are not in the medical world, when you're a fellow, what does that mean?
So, my name is Amar Kalas. I'm a second-year fellow now. Thank you for having us today. It's a pleasure. So, fellowship usually comes after residency. So we do initially medical school, depending on whether you're from the US or outside the US. It's either will be pre-med or no pre-med. And then after medical school, you decide you want to do internal medicine, and that's where you can go to gastroenterology. So internal medicine would be a 3-year residency, and then in your second year, you would decide what specialty you would want. And depending on that, you do either gastroenterology, cardiology, and so on. And for me, GI was the main thing I wanted since medical school.
And
So,
tell me why. This is always to me the curiosity of, because I don't get to speak to, and you're not a student, I get that. But when we did have medical students around the programs, I always thought, well, why are you picking the specialty that you're picking? And there's always a story attached to it. What is your story? Why gastroenterology?
for me, mainly, I wanted to do internal medicine because internal medicine, you learn about everything in the body. It's a very broad specialty and gives you options as well. And the other thing is I want to be involved in procedures. So gastroenterology is a perfect blend of this stuff where you can go do procedures and at the same time it's very cerebral, very intellectual. And if you want to grow in that side, then you can.
Perfect. So here goes my transition. And even though I said I'm going to ask you the questions last, you get the first question. But it's okay. We talked about this before we started. So the colon. And the reason I bring this up, we've got the large intestine, we've got the small intestine, we've got the colon, we've got the rectum, we've got the anus, we've got the entire thing going. If you're describing the colon to someone who really doesn't understand, we just know it's all the digestive tract. How would you describe what the colon is and what the role of the colon is in the digestive system?
Okay. So the colon is the last part of the digestive tract. It's approximately 6 foot long and goes all the way from the end of the small intestine, which is the ileum, to the anus. The last part of the colon is called the rectum. The colon in the large bowel is the same thing. The main function of the colon is mainly to form stool. So everything that's coming in from the small intestine usually is very liquid and comes in at a faster pace than where it reaches the colon. The colon's main function is to suck all that water and absorb all that water, and to a lesser extent nutrients, and form the stool so that we can excrete it. That's really the main function of the colon, and that's where, because it's a rapidly growing tissues in that lining, you can get cancers.
Dr. Kalas was saying that brings me to the question of, we've got days where we're constipated. We've got days where we have diarrhea. And so I feel like it's the decision of the colon whether to have those things happen. But in general, when people are constipated, what does that mean? Are they not drinking enough water? Again, once the food and liquids get to the colon's thinking, okay, how much do I take out? How much do I keep in? What in general causes constipation and diarrhea? I know there's a gamut of answers out there, but in general.
So for constipation, it can be something as simple as you said, someone not drinking enough water, not having enough fiber in their diet. It could be something like if somebody got recently hospitalized and now they're not moving as much, they're not walking as much. So also the colon kind of takes a rest with the rest of the body. So it's not uncommon for us to see in the hospital patients with constipation. Other things can be including medications. Some medications for blood pressure can cause constipation. So it's always difficult to pinpoint the exact reason for the constipation. And that's why you'll have someone who's constipated for a few days and then he's normal again.
Right.
And you will never really know exactly what was it that he was constipated. So as long as it's not something that's persistent, that's associated with things like requiring enemas or requiring to put manual disimpaction of themselves, then usually it's something that's transient.
Makes sense. Makes perfect sense. Dr. Zuckerman, I'm going to bring things over to you. So we're talking about the colon. We're talking about colon cancer and colonoscopies, et cetera, et cetera. He's smiling. When we're looking at a polyp, how does a polyp develop in the first place? And then after that, we're going to talk about screening guidelines and all the fun stuff with that. But since we're talking about the role of the colon and everything that it's doing, its role basically is to extract the vitamins and water out of the stool. What is it that causes a polyp? And is there an answer for that?
All right.
It just happens.
There's no answer.
There is no answer.
I think you have a picture of a polyp that might help everyone understand what it looks like, because
And that's on page 3.
A polyp is essentially an abnormal collection of cells forming a small mass, let's say. So it can vary in size. Polyps can be like a pimple, they can be a few millimeters, they can be like a mushroom, they could be on a stalk. So they come in different sizes and shapes. But I think abnormal collection of cells sort of rising up above the lining of the intestine would be a polyp. Now, we're talking today about colon polyps, because there are polyps, sort of a more general term, but this is what we mean by polyps in the colon. So the problem with polyps don't cause symptoms, or at least small polyps don't. Right. So you won't necessarily know you have a polyp. But polyps, the standard method of leading to colon cancer is the polyp cancer progression. So most of the time, cancers start as polyps. So you develop polyps, and then a small percentage of polyps over time, and we mean 10 years, we mean a long time, can get larger and develop into cancer. So that's the polyp cancer sequence. And there are different types of polyps, but generally speaking, now we're talking about adenomas or just benign polyps.
Exactly,
So
and that's
the
what you see on your screen right now. These are benign polyps, and to your point, some can look like a simple pimple, and because these are benign, they are easily removed. But this, I think, is a really nice transition into screenings and what screenings are actually looking for in the body. And Dr. Robles, you're on for that one. So I want to talk quickly too, because I know the last time we were on together, the screenings used to start at age 50.
That's correct.
And now the screenings are starting at 45.
Yeah.
And I think we may have, or if not, I'd like to repeat it, what the process is of why screenings are now starting at 45. I think it's great. I think it's wonderful. But in general, why is that happening?
Yeah, no, absolutely. So, colon cancer, like I said, it's one of the most common type of cancers there are. And it's actually going up in incidence. It's becoming more common. It's becoming more common in younger individuals. We start seeing a lot of new onset cases in individuals under the age of 50. I mean, it's to the point, it's the most common cause of cancer death in men under the age of 50. And now when you start screening at 50, it might be too late for some of these individuals. So, but decreasing the age to 45, we're hoping to be able to capture a little bit more of these population. Capture these polyps before they become cancers, where we can remove it, we can prevent cancer, and at the same time, a person does have a cancer, we capture it early, where it can be treated, it can be cured. Colon cancer is very treatable as long as you capture it early. You're not going to have symptoms early on.
Right.
So the only way to know is going in there looking for these type of things.
Exactly. And is there any information or reasons that may have been given through the world of medicine of why people that are younger are developing colon cancer earlier? Is it the type of food that we have? I always go to don't eat processed foods. But is there a thought of that?
Yes, a lot of theories, hypotheses of what's happening, what's causing these changes. It's becoming more common. Younger individuals, diet definitely, we believe, is contributing to these things. Modifiable risk factors, smoking, even though smoking in general is coming down, but yet again, our diet has changed. It's changed quite a bit. The increasing rates of obesity, being overweight, all this are contributing, what we believe are contributing to the development of early onset cancers. Increased prevalence of diabetes, glucose problems, the diet, red meats, not enough fiber in the diet. It's like Halas was saying, fiber is not only good to prevent constipation, but it can also prevent the formation of polyps and formation of cancer in that case. So all these factors are coming into play, and even some research saying that the changes in the microbiome, meaning the little bacteria that lives inside the colon, can be contributing. And so a lot of factors, a lot of things we need to keep an eye on. And as medicine advances, we hope that we'll figure out what's happening to polyp form and hopefully be able to stop it from that process.
Right.
Yeah.
And I feel like this too, and we've talked about on some other programs, that we are kind of in an obesity epidemic. And this is really the first time in history where we've had so much food so readily available, and not necessarily healthy food, because we're just in that process of society. It's like grab this on the go, grab that on the go. So it makes sense too that we've got more issues going forward. Dr. Zuckerman, yes.
Yeah, I wanted to add, this is not the answer to the question, but there is a genetic predisposition here. And we don't think the sort of the increase in younger adults with colon cancer is due to genetics. We think that's environmental, dietary issues. But I should say that there is a genetic component, and a small percentage, some patients have a family history. If someone has a first-degree relative, meaning mother, father, sister, brother, could be son, daughter, but a first-degree relative with colon cancer, that person has twice the risk of getting colon cancer as the average person. And still the same polyp cancer sequence occurs, but at times it can occur at a younger age. And there are genetic syndromes. A small percentage of patients do have this genetic predisposition to developing polyps and colon cancer.
And when you're talking about family history, are there also certain parts of the population, certain areas of the population that are more prone to colon cancer than others? Other than just hereditary? Or is that not?
I mean, there are some diseases that might predispose you if you have inflammatory bowel disease or ulcerative colitis. It's a small risk. I mean, it's not that big. But over time, that is a predisposing condition.
Okay.
And
So,
usually,
yes, Dr. Kalas?
sorry. And usually that IBD, as he said, is more in Caucasians. So, but it's not very common as a cause of cancer.
Okay.
The other times where we see that there's a difference between different populations is not really, maybe it's not from genetics, but from access to healthcare. So healthcare disparities can contribute to this. So especially in the Hispanic community, it can be more likely for them to be diagnosed with a more advanced cancer rather than an early cancer.
Okay. And that makes sense too. And I want to go back to the screening question, because I know that there are several different, if you watch television or stream anything and there's commercials out there, you've got a good old-fashioned colonoscopy, which I think is the way to go. It's the gold standard. And then you've got other ways of screening as well. And Dr. Kalas or Dr. Robles, who would like to take that on? Because I know that there are options out there. I do want to continue talking about the gold standard though, but what other options are there for people who are maybe having their first screening?
Yeah, no, absolutely. So there's stool-based tests, which are readily available, non-invasive. There's no anesthesia involved, no procedure involved, no prep involved. And it's a very acceptable way of getting screened. These stool-based tests vary, whether we're just checking for blood, whether we're checking for blood and changes in DNA, like altered DNA from a polyp. And you can see a lot of commercials about the Cologuard and things like that, which it checks for blood as well as for changes in DNA. And all these tests, what people need to be aware of, all these tests are all acceptable methods. If you participate and you're involved in any sort of screening program, whether it's the stool-based test or the gold standard, the colonoscopy, if you follow up appropriately, you will see a reduction in overall death from colon cancer. However, that only includes if you have a positive stool-based test, this is followed up with a colonoscopy.
Right.
Just doing the test itself does not decrease the risk. You need to have appropriate follow-up thereafter.
And I do want to talk, I'm going to be gross for a minute because I think it matters. So you're doing Cologuard, there's something funny, I got to go get a colonoscopy, you should do it anyway. But colonoscopy, it's if you've never had one, I think it just scares people. So I'd like to be very specific as to what this entails. And if you talk to the majority of people out there, it's like, oh, it's the prep. The prep is so hard. So the prep is, Dr. Kalas, would you like to talk about the prep?
Yeah, sure.
Okay, let's talk about prep. So you go in, it's like, you know what? We need to schedule for a colonoscopy. These are the things you need to do.
Yeah, so the prep usually starts a few days before the procedure. Usually a day before, you should only be taking clear liquids because we want to make sure that there's no food in the whole colon. And just because you don't eat the night before doesn't mean that there's no food from the morning before. So the day before, it should be all clear liquids. And then the prep, the one that's most commonly used in the US is the Go Lightly, which is Miralax, basically, but 4 liters of it. And usually it's done in a split dose fashion where it's part of it was taken earlier in the day, then the other part earlier in the morning before the procedure, to help flush out the whole colon. There are more different types of prep. There are stuff that are less volume, for example. It'll be 2 liters instead of 4 liters. They might be easier for patients who really can't tolerate golightly at all, which can happen. There are other ways as well where some people take Gatorade with some medications to help them poop, and they'll take clear liquid for 2 days instead of 1 day. So there are many options which should make the prep now easier.
Exactly.
Yeah. Yeah, and there's a lot of ways to make it more palatable. Some people take it with Gatorade instead of with just water, so that there's some flavor. And that should help. It's not the best experience. It's 4 liters and it's only clear liquids the whole day, but it'll save you a potential cancer.
Absolutely. And so the gross part I'm talking about, because again, I like being blunt. It's a medical show. We're educating people. And I will say this because I had my second colonoscopy at the end of last year. The first colonoscopy, I did have go lightly. Second it was all over the counter. Second colonoscopy, it was, to your point, Gatorade, some medications, and you are having diarrhea for about 8 to 14 hours, 15 hours. Do it as much as you can the day before so you can get a good night of sleep. But that's, sure, it's uncomfortable, but we've all had it. And I joke and I say, well, this is a great cleanse, isn't it? And you kind of start from scratch once you have your colonoscopy. Joked about that last time too.
And the most important,
the
most important thing in the colonoscopy is to be able to see.
Exactly, you need everything out of that system.
Yeah, so if there's stool, there's some stool we can clean out, but some stool that we can't.
Yeah.
And that would just have to be repeated again.
Exactly. And again, why go through all that? Yeah. So go through it. It's worth it. Trust me, it's worth it. Dr. Zuckerman, what I'd like to do is go to another slide that we have here, and it is actually talking about the polyp removals. And so with the procedures that you all do, and thank you for talking about this before the show, the slide that we have in front of us, these are cold snare procedures, meaning that there's not a cauterization afterwards. And I'm going to try to say it right. This is a polypectomy, a cold snare polypectomy, correct? Yeah. He was messing with me. I'm see? I knew it because he just said, just call it this. And I'm like, I can't say that. That's too hard of a word. But in general, talk about cold snare for the smaller polyps. And then when you have to cauterize, and feel free to just kind of chime in, anyone that's listening.
All right, but I wanted to agree with Dr. Robles and Dr. Kalas that, first of all, there are 2-step screening procedures or 1-step screening. So 1-step screening is colonoscopy. This is the gold standard, most effective. 2-step means if you take the stool test, the fecal immunochemical test, FIT test, or the multi-target DNA FIT test, which is Cologuard is the brand name. If these are positive, these are somewhat sensitive. If you take it and it's positive, the next step is you need a colonoscopy. So you don't get out of a colonoscopy. The colonoscopy is a preventive test. Only colonoscopy can remove polyps.
Correct. Yeah.
The other one is just detecting. It's really more detecting colon cancer or advanced polyps. It's not detecting tiny polyps. And then there are the more limited use tests like CT colonography you might have heard about, or some sort of compromised flexible sigmoidoscopy. But for the audience, really, any screening test is better than nothing. If we're doing a colonoscopy, as Dr. Klaus pointed out, you need an absolutely clean colon to do a high quality job finding polyps. Once you find polyps, how do we remove polyps? Well, really tiny ones, 1 to 3 millimeters, we might use a biopsy forceps and just take a bite and remove it. Otherwise, small polyps in the 3 to 10 millimeter range, we would put a catheter through the colonoscope, and it looks like a little snare or a lasso around the polyp and just take it off. That's called a cold snare, polypectomy. So we're just cutting it off with a circular wire. and then we suction it through the colonoscope, catch it in a trap, send it to pathology where it's looked at to get the exact type of polyp it is. For larger polyps or polyps on a stalk, we would do the same thing, but it's a hot snare.
And when we say it's a hot snare, does it mean it then burns the tissue behind? And so that's the cauterization?
Yes, electricity,
Okay.
cauterization.
Okay.
There's a small risk of bleeding every time you do a polypectomy. So these are just techniques for doing a polypectomy. Then there are some more advanced techniques for larger polyps.
And what would
But
that?
that,
Yeah, or does that go to one of these guys?
let me ask one of these guys.
Let me ask one of these guys, since you are the chief, right?
Yeah.
Since he's the chief, he's asking one of you guys. So what is the third removal of polyps? The
So
fellow
there's-
takes that one. Thank you, Dr. Kalas.
So there's endoscopic mucosal resection, where basically we would inject some liquid under the polyp, if it's big, to lift it up, just so that when we're removing, we don't remove too deep where there's a high risk of perforation. Especially when we use the heat, this heat sometimes transmits through the wall. So we want to minimize that by lifting it up. So that's one way. And then there's a newer way now, the endoscopic submucosal dissection, which is basically using like something similar to a knife and slowly cutting it around its edges. And this is more useful for very, very large polyps where you don't want to remove it in more than one piece. Because when we remove it in more than one piece, you're more likely to miss a few tiny pieces.
Right, that
behind.
makes sense. And those obviously, again, and the reason I ask this too is people, and I do want to talk about side effects, for lack of a different word, or things that could result in some bleeding. And if that is the case, what is the course of action after that? Say there's some bleeding, which I think is very natural. If it lasts for what, more than a day or 2 days? Would a person be able to see this in their stool?
So depending on the way we remove the polyp, like we were talking about the cold and the hot, actually that has something comes into play in determining the bleeding. With a cold snare, you're able to see if it's bleeding right there and then. You cut, it bleeds, we have the chance to stop it. Sometimes it bleeds for a little while, it stops bleeding, but we're able to see that it stopped bleeding. The individual may see a little bit of blood in their stool, maybe that day, the day after, but that should probably be it. And that's actually acceptable. It's not be concerned. It's when we start using the heat source, the hot snare, the cauterization, where it's not going to bleed because we burn through the process, through the cutting process. We put some clips to close off the area. But however, once this kind of starts wearing off, individuals can sometimes develop bleeding maybe 5 to 7 days later. And this bleeding tends to be a little bit more, is larger volume than your cold snare. And most of these individuals will come back to the hospital. And if that happens, we will have to go back in and try and close that area back again. It's rare. It's rare. It does happen, but it is a rare possibility. Yeah.
And the nice thing is that there is a fix.
There's a fix.
Bottom line, there's a fix
Yeah.
for that. Excellent. The next slide, which is the fun slide, this is where you don't want to get. So I'm just gonna have some fun with this and say, okay, this is a 62-year-old who decided that he didn't want to do his colonoscopy, and of course he's a he. Maybe she didn't want to do his colonoscopy or her colonoscopy, and now we've got cancers. When we're looking at someone who does have a colon cancer, I've got several questions. The biggest one, how do you treat it from there? Do we go in and try to remove these, snare off? Do we take some of the colon out? There's all kinds of answers here, and I'm throwing this out to whoever wants to take it first. And since you're the chief, you get it, Dr. Zuckerman. Is that okay?
Well, yeah, in the case that you're that you're describing, if we see something that looks like a mass in the colon and we biopsy it, and it turns out to be colon cancer, then the primary treatment is surgical. Now, we'll do a workup. We're going to have to get blood tests and CT scan and check to see if this is localized or spread beyond the colon. But the basic treatment in early detection, localized cancer, is surgical removal.
And when
All right,
you say
then
surgical removal, describe what you're talking about.
we
Would it
refer
be-
to surgery. Then
Okay.
we take, for instance, if this is in the lower part of the intestine, then the surgeon may take a piece of the sigmoid colon out, let's say, and remove that and reattach. So it varies depending upon location, and the rectum is a little more difficult to deal with. And we talk about colorectal cancer. It's sort of the rectum, the last part of the large intestine at 15 centimeters or so, and the rest of the colon. So there might be a slightly different approach to the two, but the basic treatment would be surgical for early cancer, or not too invasive.
Okay. Dr. Robles, if we can extend that a little bit too now and say we've got several areas that are cancerous within the colon. If you take part of the colon in one area, can you take another part somewhere else? Do you, I guess, depending on how close together they are, you would section that off? In general, kind of carry that a little bit further. And how do you section the colon back together, the parts that are still good?
So absolutely. So having cancer in multiple areas of the bowel, it's rare. It does happen. It does happen. It's rare. And usually, unfortunately, a lot of these individuals tend to have a little bit more advanced disease at the time this happens. So a lot of these individuals will probably be treated with chemotherapies first to try and decrease the size of the tumor before they do any sort of... Before the removal.
Okay.
That's correct.
Okay.
Now, and it depends on the colon. I mean, if you have two masses in the right side of the colon, sometimes just cutting off the right side of the colon, and you kind of connect the small intestine to the remainder of the large colon, that can be a possibility. That can be a possibility. But when you start dealing with cancers in one that's in the right side, one in the left side, then it starts getting a little bit more complicated. And this is, we work very closely with our colorectal surgeon colleagues as well as our medical oncologists, in a way we plan what is the best course for the management of certain individuals. But like Dr. Zuckerman was saying, I mean, early onset cancer surgical approach, I mean, you just literally just cut that part of the bowel, you put that part of the bowel together, it's cured. If you capture that cancer early, it is a cure. Most early cancers don't have symptoms, so that's why the colonoscopy comes into place. And again, colon cancer, 90% survival at 5 years, as long as you catch it early. It starts going down quite a bit and once you have a little bit more advanced type of disease.
So now let's talk about someone who has had the cancer, has now had the surgery. From their point on, because now it's self-history, not just family history, it's themselves. How often should they go back and have a colonoscopy from then on out? Is there a certain first couple of years, and then, I always think about the 5-year mark. Like after 5 years, it's like not that you're clear, but you're relatively clear, right?
Good question. So initially, after the initial surgery, you'll have a follow-up colonoscopy, usually at the 1 year time frame. At the 1 year time frame, everything goes well that time. That colonoscopy, there's no polyps, there's no cancer. You have the next one in 3 years. And after that, it'll be 5 years. And instead of doing every 10 years like an average individual, you'll be screening or surveilling at a 5-year interval from now on. Just because you develop cancer once, technically you may have a little bit higher risk for developing it again. So we keep a little bit closer eye on these people.
Nice. And I missed it a little bit earlier, but when you have, when a 45-year-old goes in and he's good and he's doing his first check and is completely polyp-free, then he doesn't have to do the test for another
10 years.
10 years.
That's right.
So that was my first case. My second case, I did have a polyp, little itsy bitsy baby polyp. It was benign, but now I do my checkup in 5 years.
One polyp?
One polyp, yeah. Oh, look at me, I'm testing. I don't mean to test you. It didn't come out right, but now I do my second follow-up in 5 years. Even though there was nothing wrong, there was a polyp, they did remove it, so it's like, okay, I am a person who developed polyps. I actually had a polyp removed from my tonsils about 15 years ago. So there's just something in my system that I know I might become a polyp girl, so I'm just like, I might just go in after 3 years. I like to really check that out. I would like to talk a little bit too about colostomy bags, because that is often talked about with the world of not colonoscopies, with colon cancer, with surgeries. When is the colon in a shape to where a person would need a colostomy bag? And is that forever, or can that be reversed? And I'm throwing that at Dr. Kalas. Would you like that one too?
Yeah. So
look at me putting him on the spot.
The colostomy bag requirement really depends on, first of all, the location of the cancer. How much colon did they remove? Did they remove it emergently, or was it elective? So whenever it's usually emergent, usually they'll have a colostomy, at least temporarily.
And let me back up, because I didn't explain what it is. First, explain what the colostomy bag is. I should have said that.
Yeah, colostomy bag is basically when they bring part of the colon or the small intestine, actually the ostomy for the small intestine, but they bring part of the colon to the skin, and it'll be an opening on the skin where the stool comes out from. So when it's done emergently, it's usually done for an obstruction. In these cases, they'll put the colostomy bag so that the obstruction is relieved, and then they'll plan about the surgery and what approach to take, what part to take. Usually it's reversible, but if somebody, for example, has his whole colon removed with the rectum, then they might be with the colostomy bag forever. But in general, it's reversible.
I like hearing that. Okay. I worked with the American Cancer. That's how this program started 28 years ago. I was working with the American Cancer Society, and one of our volunteers had a colonoscopy bag. It was the first time I've ever seen or knew anything about it. I was in my 20s, but she was great about just going around people, showing them what this is. This might be your surgery. I'm fine. She was the most lively person I knew. So I just thought to myself, this is great. I do have a quick question. We were talking about symptoms, and that often there are no symptoms. I want to quickly go into, because this is kind of a gastro show, I want to go into irritable bowel syndrome for just a minute. I know it's not about that, but I have a son-in-law, and literally this weekend he had an emergency appendectomy. Why am I talking about that with colons? It's just something's hurting, something's not right. If people are at the point where they do have a colon cancer, if something doesn't feel right, go get it checked out, even if you are that 62-year-old person that hasn't been there before. But when colon cancer is a point where there are symptoms, what does it feel like? What are they looking for? Are they looking for blood in the stool? When they, have them look back in the toilet and see? I'm throwing that out there again to anybody who wants it. Dr. Zuckerman, you haven't talked in a while. So
Yeah.
How about that?
I wanted to make one comment about, you were asking about after colon cancer.
Mm-hmm.
So we call it colon cancer screening when someone has no history of colon polyps or colon cancer. If we find a polyp, or if someone should have colon cancer, after that we call the procedure surveillance. It's no longer screening. The patient has a polyp or cancer, and we do surveillance. And so here we're talking about different surveillance intervals. And this depends on the polyp, the size of the polyp, the number of the polyps. Colon cancer is another category. So all these, you mentioned one polyp, depends on the size and the type. And so there are all these different intervals, but the best you can do is 10 years. Anyway, there's an overlap of symptoms with people with bowel problems, and certainly irritable bowel syndrome symptoms may overlap with colon cancer syndromes. With colon cancer in particular, there are alarm symptoms or alarm signs. There are certain things that would definitely draw your attention. When we're screening, we're really talking about asymptomatic patients without complaints. But symptoms could be change in bowel habits. You're suddenly going less frequently, or change in stool caliber or consistency. Now your stool is pencil thin. You're straining. If there's blood in the stool, gross blood, this is a problem. It may be hemorrhoids, but we can't assume it's hemorrhoids.
But I do want to talk about that because a lot of people have that issue. So I'm glad that you brought that up. Yeah.
So blood in the stool, for sure. Also on blood tests, if you're anemic, or you have a certain type of anemia that suggests chronic blood loss, that would be a big one. So these are some of the things we could look for.
Yeah.
Okay.
I do want to add,
Yes.
the blood in the stool, it should never be taken as just hemorrhoids. Never. That's one of the causes we believe that younger individuals were postponing their procedures because, I'm too young for colon cancer. This is just hemorrhoids. So anytime there is blood in the stool, this is an alarm symptom, like Dr. Zuckerman was saying. This is something that definitely requires an evaluation. Don't ever overlook blood in the stool. It's always something that needs to be investigated. Cannot be put on hemorrhoids unless we do the colonoscopy at that time.
I like the way this is set up, and I know Dr. Kalassi had something to add to that. Within that question, so blood in the stool, depending on how fresh the blood is, could look differently. So I would love to take this moment to describe what that might be. So fresh blood maybe hemorrhoids because it's fresh, meaning bright red blood, versus blood that looks a little bit red-brown, rusty. Let's go through that for a little bit and what people might be looking for, what they might recognize.
Okay, so using the blood color alone is never accurate.
It's never accurate.
Because it could be that the stool, for example, or the blood stays longer in the colon, so the color will change. So somebody who poops once a week will likely have a different color of blood than somebody who poops every day. So the stool color on its own is not accurate. It can give you an idea. If it's fresh red, as you said, it could be something more on the left side or more distal, like hemorrhoids. Even like an anal fissure that's really badly bleeding, or it could be a cancer. Other causes could be also contributing, like diverticulosis, somebody who's bleeding from that, an ulcer that's unrelated to cancer, like people who take NSAIDs or people who are having a ischemia or something. And then the right side tends to be a little bit darker, the blood there. It'll be sometimes even black, and it'll be confused as an upper bleed, but usually it'll be darker.
And is it the right side is darker because it's just farther away?
It's farther away.
Okay.
Yeah. So the longer the blood stays in the colon or inside, the more it's going to be metabolized and change the color. That's why the upper, for example, usually causes black. The lower is more reddish, maroonish.
Okay.
Just because of the duration and everything.
And bottom line, again, I'm being blunt. We kind of all know what our stool looks like. Get used to it. Look at it every now and again, so that when you do look at it, it looks different. That's when it's time to pay attention, for the lack of anything else.
Yeah. Sorry, just to bring it back to
I'll
IBS, as you said. So IBS should never have bleeding. If somebody has bleeding in IBS, it should always be further evaluated to make sure it's nothing else. It could be hemorrhoids, but we have to make sure that it's nothing like cancer, because patients with IBS, usually they'll have more complaints. They'll be going to their doctor with complaints of abdominal pain, which must be frustrating for the patient. But sometimes it might be taken lightly, and that will cause misdiagnosis. So weight loss, blood, severe pain out of proportion, all of these should be investigated more.
Okay. And IBS, if I didn't say it earlier, IBS is irritable bowel syndrome, or inflammatory bowel disease, is something that people talk about too. On that note, and I want to talk a little bit about the couple of things that you mentioned, which I think is great. We're looking at fistula, we're looking at diverticulitis, and we're looking at ulcers. So let's talk about a fistula. What is it? What I know, it's like a little pivot or a little, I guess. Yeah,
it's like a small cut
in
the perianal area. It can happen if somebody strains a lot, is very constipated, has very hard stool. It can sometimes make a tear. And this tear can make the patient more scared to go to the bathroom, which will worsen the constipation. They'll hold it in longer, then they'll go in, make it bigger again. So they have to mainly avoid constipation. There are some medications for it. But that's the main thing for fissure.
And will it heal on itself, or is that something that a person will always have?
No, it can heal on its own. And if it's not healing, then there are medications to be given to relax the sphincter so that it starts healing the skin slowly.
Excellent.
But the most important, no constipation.
Yeah, that's the big thing. Ulcer, I think we'll save that for a different show, but diverticulitis, I think, is something to describe. And is there a higher risk of any type of colon cancer if you have diverticulitis? Is it related at all? And if not, since you're shaking your head, actually, I'll give you a break. Dr. Robles, let's talk about what diverticulitis, just describe what it is.
So diverticulitis is an inflammation of diverticulosis. So it's actually an underlying diverticulosis. Little pouches that form in the bowel can usually arise when a life of maybe low fiber diet. So lack of fiber, your colon is having to squeeze more, having to work extra hard, and this results in maybe pouches that form. These pouches are benign. They don't increase the risk for colon cancer, but they do put you at risk for diverticulitis, which is inflammation of one of these pouches. Maybe one of these pouches gets obstructed with a piece of stool, what we call fecal lift. Inflammation happens, it can develop an abscess, and sometimes even develop a perforation. Part of that bowel can open up, and then it becomes an emergency. Then you may end up with an ostomy bag as well during that time. So that's what we want to prevent. High fiber diet helps prevent that, stay hydrated. And again, not a true association, but it's associated with low fiber, and low fiber is also associated with colon cancer. So fiber prevents constipation, helps decrease the risk for these other causes.
And drink water.
And water, exactly.
Even if it's Gatorade to mass taste. I get that.
And I just want to add something to what Dr. Robles said. So diverticulosis doesn't have a risk for colon cancer, but sometimes patients will have diverticulitis. Usually after 6 to 8 weeks of the initial episode, we should do a colonoscopy to look for a cancer. Not because the diverticulosis caused the cancer, but sometimes the cancer can precipitate diverticulitis from surrounding inflammation.
So it's like not one causes the other, but opposite way around.
Yeah, it can be hidden.
Yes, it could be hidden. That makes a lot of sense.
And along
Dr.
the
Zuckerman?
lines of you had a question previously about colostomies, so colon cancer is not the only reason you might get surgery and end up with a colostomy. It's in an emergency setting, but diverticulitis, for instance, diverticular complications might be another reason you need surgery and then temporary colostomy. Also inflammatory bowel disease, like ulcerative colitis or something like that in an emergency. So, or after surgery for inflammatory bowel disease. So there are different reasons, not just colon cancer.
Exactly.
All these things overlap. That's why medicine is difficult.
It is a complex thing. And our bodies are complex, but I'm super happy that you're bringing this up because I do have several things that I have here too. Ulcerative colitis I was talking about. And again, when we talk about inflammatory bowel disease, now when you have the word disease, it's different than a condition. So people that have the disease, what are they looking out for? And when do they have in the back of their heads like, okay, do I need more colonoscopies than the normal average guy? Do they not? Just throwing that out there again, Dr. Robles?
Yeah, so inflammatory bowel disease, which is separate from IBS, irritable bowel syndrome.
Correct, yeah.
Actually encompasses what we call Crohn's disease and ulcerative colitis. So entities with ulcerative colitis maybe being a little bit more common than Crohn's disease, but these are conditions that involve inflammation in the colon, and in Crohn's disease can involve inflammation in the esophagus, the stomach as well. Now, inflammation is usually the precursor to cancer. Because you have underlying inflammation, your risk for cancer in the colon does increase. It's why these individuals actually undergo what we call screening more often than your average risk individuals. We recommend screening every 1 to 2 years for people with inflammatory bowel disease.
Okay.
Actually, there's a few caveats that involve like how much of the bowel is being involved, things like that. But just in general, usually at 1 or 2 year intervals, we're screening these individuals just because of the higher risk, because of the inflammation.
Okay. And I'd like to expand a little bit on Crohn's disease because I'm trying to think too about the audience and what I see or hear commercials about, advertisements about. It's like Crohn's disease. If you feel like you have to go, what are some of the symptoms of Crohn's disease? And say somebody has symptoms, but they don't know what it is that they may be experiencing. And I know a lot of this, as Dr. Zuckerman said, it kind of all, dances with each other. Crohn's disease is what? How would you define Crohn's disease?
Crohn's disease will be defined as an inflammatory condition affecting the entire gastrointestinal tract, more commonly the large bowel, but also the small intestine. Small percentage of people can involve anywhere from the mouth to the esophagus to the stomach, but the small bowel as well as the large intestine being the more common. Symptoms can include abdominal pain, diarrhea that happens even at bedtime, at nighttime, what we call nocturnal type of symptoms. These individuals can be losing weight, can have blood in their stool, and these are kind of reasons why they seek care. We do imaging studies, we do colonoscopy, we see inflammation, we make the diagnoses at that time.
Okay, and the nice thing too is the commercials I'm hearing is because there's medications out there to help out.
Absolutely. So we live in a time where there's medications on a daily basis coming out, and
oh my gosh,
great medications, by the way, great medications. Not only are we decreasing the inflammation, we're giving individuals a better quality of life. So that's the other benefit of finding it and treating it.
Great. Dr. Zuckerman, you mentioned earlier that a lot of times, and I feel like when I first started doing the show, again, 28 years ago, we did often say colorectal cancer. And I feel like that's been separated over the years. But you did talk about there's a difference between colon and, if there's a polyp or a cancer in the rectum. I do want to address that really quick because there are different nerve endings in the rectum and just different issues. Can you expand a little bit more on that?
I think it's just a little difference in the anatomy of where the rectum is and the rest of the colon is. It's still colorectal cancer, or CRC. It's the same as saying colon cancer. But rectal cancer is managed a little differently. There's more chemotherapy, radiation therapy, more difficult surgery than the rest of the colon. In terms of polyps and finding polyps and removing polyps, then similar.
Okay.
So they're not really distinct entities.
And for visual,
Yeah.
how big is an average rectum before it gets to the colon?
When we do
How
a
long?
colonoscopy, we start with the anus. We go into the rectum between 15, 18 centimeters. We're in the sigmoid. We're out of the rectum. So
Okay.
about the first 15.
That's really small.
About the first 15
Okay.
centimeters.
Okay. I thought
7
it'd be-
inches.
Okay.
Hard to say.
And so here's another question. I'm just thinking as an audience too, right? When somebody has hemorrhoids and we have pictures here of polyps and we're like, well, I think that looks like a hemorrhoid. Maybe my hemorrhoid and or polyps are at the very bottom of my anus. These are hemorrhoids. And I'm asking all three of you because when people come to you and they're asking you questions, what are some of the questions that you often get asked about that very subject? We know the difference between hemorrhoids and, well, maybe we don't. Let's talk about the difference between a polyp that may be at the very, very end of the rectum, which is why I was talking about that, or hemorrhoids. How does someone who has no idea in the medical world, how do you differentiate that? Dr. Robles, you're looking and smiling and nodding,
Yeah,
so
no,
you
it's
get it first.
It's a great question. So with our cameras that we use, our colonoscopes, we have different ways to help us determine what we're looking at. Now, it's rare. We can't tell the difference between a polyp and the hemorrhoid. Sometimes there's a polyp on top of a hemorrhoid, and then that's when it becomes an issue because
Wow.
yeah,
Okay.
you need to cut something off, but it's on top of a vein. So,
Right.
But we have ways of doing things, but we also have a lot of ways to help us determine the difference. And again, we can see the extent of the hemorrhoids. Not only are they going outside, but how far deep inside are they going? Because they're going to be managed differently. I mean, in general, high fiber diet, not sitting in the toilet for too long, are all ways that we can decrease the hemorrhoid type of issues. But again, the polyp, with our cameras that we have, we're able to turn on different type of lights to help us see different angles, different colors, and we'll be able to differentiate at that time.
Okay, and you hit the nail on the head too, a definition of a hemorrhoid is a vein that is exposed and popping out, for the lack of a better word. Is that, and Dr. Carlos, you're smiling and nodding, so how would you describe that, or how have patients described hemorrhoids to you and their worry about them?
Exactly as you said. It's dilated veins. Sometimes it depends if they're external or internal. External ones are the ones that can be felt more commonly. So external ones are the ones that also have more pain. So the internal ones bleed more. The external ones have more pain than bleeding. So it's usually will feel like a small, I don't know how to describe it, small cherry maybe. That's
Grapes, the way
grapes.
Full disclosure, when I was pregnant, I had my first baby at 30, had no idea what a hemorrhoid was, and boom, popped the baby out, and there was all kinds of stuff going on down there. And I thought, what in the world are these? And I remember asking the nurse tags, I had no idea. And she goes, oh, just think of those as mini grapes. Little by little, they'll just pop right back inside. And again, I'm being blunt, but that is through the women that I have known who have had babies that have not ever had hemorrhoids before. That's the way it was described to me. I had no idea that was even a thing until then. So that's why I wanted to bring that up. We are at about 4 minutes before the show wraps up. So, Dr. Zuckerman, what would you like to add?
I wanted to mention the Texas Tech program, Success or Axion. So this is a colon cancer screening program run by the Department of Family Medicine. Dr. Maloku is in charge of this program, and it's meant for colon cancer screening, free colon cancer screening in patients who can't afford it, who are at high risk. So this is a grant from Texas Cancer Prevention Services Foundation. But anyway, we've been doing this for about 13 years now. Originally it was called Axion, A-C-C-I-O-N, against colon cancer in our neighborhood.
Okay.
And it sort of morphed into the Success program now. Southwest Coalition for colon cancer prevention. And we conduct this program at University Medical Center on Alameda. where patients are referred if they meet criteria, if they meet certain criteria and don't have funding for free colon cancer screening. It's been tremendously helpful to the individuals and to the community. We've done over 3,000 colonoscopies, and of course, we found many polyps and several colon cancers, generally at an early stage. So this is a great program, and I
And how do
wanted to
people
mention
find out
this.
about it or get in line, so to speak?
You know, they go out. We can contact Department of Family Practice.
Okay.
We can contact the Success Program directly. But it also goes out. We have promodoras who go out into the community, and some of them is at religious places, and some of it is community fairs, and they hand out questionnaires. They hand out fecal immunochemical tests, FIT tests, or ask people about family history. They may have a family history of colon cancer. So those are the specific targets. Okay. People who have evidence of microscopic evidence of blood in the stool or family history of colon cancer without funding. So really beneficial program to the community.
What a great program.
And I can mention,
yes.
We won an award from the American College of Gastroenterology.
Nice.
Called the Scopie Award last year for this program.
The Scopie Award? Okay, I kind of love the name of that. Just saying, that's a perfect way to end the program. For the team that has won the Scopie Award, I want to say thank you very much to Dr. Zuckerman, also Dr. Robles and Dr. Calas. You guys have been an absolute joy to have on the first program that we have here at the Turner Home. Again, the El Paso County Medical Society has been here since 1946, which is fantastic. This has been a great program on colon cancer prevention, diagnosis, and management. If you were able to catch the whole show, that's great. But if you want to watch certain sections again or any other programs that the El Paso County Medical Society has done, you can do that at 3 different platforms. One is pbselpaso.org. The other one is the El Paso County Medical Society's website, and that is epcms.com, and also youtube.com. So you can go on there, search the El Paso physician, and then find the topic that you want to watch. Thank you so much for watching. I'm Kathrin Berg, and this has been the El Paso.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.